by a miracle of scheduling, the final presentation fits in really well with what Nick was saying, because we've got Charlotte Eost-Telling, who's going to talk about the rapid review of digital technologies to prevent falls in people living with dementia. So Charlotte, thank you so much for waiting here, and over to you.
Okay. I just move up. Can you see? Is it going to start? Can you see that?
Yes,
Okay.
still working.
Great, thank you. Excellent. Right, yes, thank you very much, Joe, and thanks for inviting us to come and share our review this afternoon. So I'm going to talk about a briefing we delivered to DHSC in January this year, looking at the evidence around digital technologies to prevent falls in people living with dementia. It's a rapid review that's undertaken as part of a request from DHSC to understand the use of technology to support independence and safety amongst people living with dementia. Now, colleagues at LSE have done the other part of the review, which is looking at the use of digital technology to support people living with dementia and their carers. But we specifically focused on the use of technology to prevent falls in older people living with dementia, because we felt that's a really important area which warrants a separate review. So this is the team who worked on the project. It was across the whole of the Older People's Policy Research Unit across Manchester, Newcastle and LSE. So a bit of background. Well, DHSC are currently developing their new dementia strategy, and it will focus on how technology can be used to support people with dementia. And the strategy is being developed in parallel with work being undertaken by NHSX to explore how technology can be used to keep people in their homes living independently for longer, and how technology can be used to prevent falls among people with dementia and older people more broadly. So DHSC asked us to carry out the rapid reviews so that they could establish the current evidence base and use the information to feed into their new dementia strategy. So a bit of background, we know that falls are a really important issue in health and social care. It's estimated they cost £4.4 billion a year in additional costs for health and social care services. And we know that older age and frailty are the biggest predictors of falls and fall risk, but we also know that having dementia makes you 2 times more likely to fall and 4 times more likely to have a recurrent fall. And some of the reasons for that are universal across older age, but some of them are more relevant for people with dementia. So, for example, there are issues with mobility, balance and muscle weakness, which can impact on gait and people's ability to get themselves upright when they start to fall, and also maintaining that upright posture, stopping them falling. Get rid of that. There we are. There are difficulties with memory and finding their way around, so that can make everything seem unfamiliar every time someone encounters a new situation. There are also greater risk of depression, and we know that depression is linked with falls, but also people living with dementia are more prone to risky behaviour. So where somebody who's not cognitively impaired might be wary of a new situation, people living with dementia might not see the risks which present themselves to them. There's also difficulties with vision processing and reacting to situations, which again can make it difficult to judge what's happening. And finally, medication. So a lot of people with dementia are on medication that causes drowsiness, dizziness, or lower blood pressure. And all of those things can add to the fall risk for people with dementia. So any technology that can be introduced that can reduce the risk of falls and reduce falls can have huge potential. So our review aimed to answer the question, what's the evidence that digital technologies can reduce falls and the fall risk for people living with dementia? And this is really important because we know that the number of people currently living with dementia in the UK is approximately 900,000, and it's predicted to rise to over 1 million by 2025 and 1.6 million by 2040. But we also know that, so that's going to cause a increasing burden on health and social care, but we also know that people who with dementia, when they do fall, are more at risk of sustaining an injury or a fracture. So the outcomes from that fall are less good, and that can be exacerbated because they're also sometimes denied rehabilitation when they do fall. So I say any technology that can help reduce falls in people living with dementia has the potential to make big impacts. But the technology in this area is evolving rapidly. We don't really know a great deal about which are the most effective and the most cost-effective technologies for people with dementia. So in terms of relevance to policy, this review is going to be a review of the existing evidence that will inform the implementation of the technology strand of the dementia strategy, highlighting what technology is being used, what works well and what the limitations are, and any barriers to implementing technologies. It's also going to be identifying gaps in the evidence base and directing future research efforts, which will help generate new insights for policy. So, as I said, this is a rapid review, and it really was. We've completed the review in about 3 to 4 weeks, which is really fast for what we're doing. So, because it was so fast, we had to base it on previous work and draw from that previous work to help speed the process up. So, within the policy unit and the Healthy Ageing Research Group at the University of Manchester, we've done quite a lot of work on technology and older people. And we used that to draw the search terms out for this project. So we looked at, there's a project about the effectiveness and cost effectiveness of strength and balance EXA games. A project called Map the Apps, which reviews digital approaches to support the engagement of older people in strength and balance exercises. And promotion of physical activity using mHealth and eHealth. And when I say mHealth and eHealth, I mean mobile health, electronic health. So anything that has a mobile or an electronic element in promoting physical activity. So we used those terms to develop the search terms for the technology and falls aspect of the review. And then we combined that with selected search terms from a NICE project that looked at dementia assessment, management and support for people living with dementias and their carers, which was undertaken in 2018. We followed a systematic review approach and then also looked for any primary studies that were published after the most recent review. And we used these search terms to look at exergaming, falls and dementia, digital approaches to strength and balance training, falls and dementia, and also the use of mHealth and eHealth with falls and dementia. And we searched 7 databases, including Embase, Medline, CINAHL, and PsycInfo. And we found 189 papers that were potential to be included in the review. Once we got rid of the duplicates and screened on title and full text, we ended up with 7 systematic reviews and 1 scoping review that met the inclusion criteria. But the scoping review actually only included 1 paper looking at dementia and falls, and that was covered by the systematic reviews, so we excluded that from the rest of the review. So we looked at the emerging evidence, and we did actually look at putting the technologies into a typology, but for this we also grouped the technology according to the emerging evidence. So we looked at environmental sensor-based systems, exergaming, virtual reality, apps, wearable technologies and sensors, and then additional primary studies. And I'm going to talk a little bit about each of those in turn. So environmental sensor-based systems and video systems, these include things like sensor lights that turn on when people trigger the sensor, and they can lead a path of light for people to go to the bathroom or whatever. Also things like bed sensors that are pads in beds that note when people have got out of bed or when they're moving around. So we found 2 systematic reviews that included sensor-based systems. They were both in community settings. So the first was in community settings, looking at sensor-based interventions. And the evidence was, there was evidence that the probability of falling was lower in one of the studies, but the other one showed no differences really, and it was a much smaller study. The problem was that there were big differences in the types of technology interventions they had. So the first one that reported the difference was part of a suite of technologies that included sensor lights and also an electronic bracelet and a teleassistance service, whereas the second one only actually included a sensor light. So that it's quite difficult to compare different studies because they're so different in the technology they're introducing. So the second review was on bed exit alarms. So that was when people got out of bed and it could ring an alarm and someone could help and assist them. This was in long-term care settings, and there were 3 studies that reported falls. 2 showed no difference in fall prevention, and the third one did show a difference in falls prevention with the alarm, but it was actually when the alarm was removed. But as the author said, the problem was that the people who worked in the care home found the alarms really annoying because they kept going off. So they were actually quite pleased when the alarms were taken away, and they were worried that that had influenced the results of the study. So really, it's very low evidence, and we can't rely on that. So looking at exergaming and commercial game consoles, so these are things like Wii Fit, Nintendo. And in exergaming, we mean anything that's a physical activity, that's a whole body movement that combines exercise and a cognitive aspect as well, usually. We found 3 studies that work in community and assisted living facilities, and none of them rated falls per se. So, but they did include surrogate measures, so things like time up test and the 2-minute walk test. None of them, so one reported a significant improvement on those surrogate outcomes. And within the two RCTs, they didn't find any significant differences, but one found a significant improvement on the Berg balance scale, which can be an indicator of a propensity to fall. The second review included 41 papers, but was across the whole of range of different diseases, not just dementia. And they concluded that although exergaming improved balance dysfunction and was safe for people living with neurological conditions, the amount of data they had for people who had dementia was so low that they couldn't draw conclusions specifically for those groups. So if we move on to virtual reality, we found one systematic review on the use of virtual reality, looking at health outcomes for older adults. And this was using immersive virtual reality. So like this headset that you have that displays an image in front of you. The study it projected an image of people at the top of stairs and projected them starting to fall down those stairs. And they measured posture and falls, and they found that people living with dementia had a significant reduction in postural stability. They had a longer lag time in cognitive strategies to upright themselves, and there was a delayed reaction to falling. So they did find some useful data that could be used maybe in the future to help develop technology to train people maybe to stop them falling. Interestingly, we didn't find any systematic reviews looking at app-based interventions for dementia and falls. And we're quite surprised about that, but I think just at this stage, there's quite a lot on older people, but not on older people, dementia and falls. Then the final area we looked at was wearable technology and sensors. So this includes things with, for example, a gyrometer or a can tell whether you're upright or not. So they could be body worn, they are body worn, sorry, and they can be wrist worn, ankle worn, or they can be on your back. So there's lots of different places for wearing them. And the first review of this had a whole range of different studies, some of which said they included people with dementia, but the authors of the study also included 10 additional studies that didn't explicitly state they included dementia, but the authors decided they would include them because they were community-based projects and they assumed that people with dementia would be part of the cohort. So that study concluded wearables were acceptable tools to assess fall risk, and the sensor data from real life data was more valuable and better at predicting falls. So some of these were hospital based and some were community based, and the community based ones were better at predicting. But they also concluded that then we need more research to determine which aspects of motor performance best predict falls. The second review included 3 observational studies, including focusing on predicting falls. Again, 2 were in the community and 1 was in a lab. So the 2 in the community found that sensory data was useful for classifying gaits of fallers, and the 1 in the lab found that physical activity measures could predict falls. But they also recognise that there's more need for standardising tests and for more information about what can predict falls in a real life situation. So finally, just some additional primary studies. We did review any studies that had been published since 2020, because that was the last study that was included in one of the systematic reviews. We did find that they didn't actually change the findings from the rest of the review, but just to put in context, we had maybe 3 that were quite interesting. There was a pilot RCT on the effects of assistive home tech, and that showed a significant drop in falls in the bathroom, but not elsewhere. But those falls, that fall measure was actually part of a big battery of tests and a big battery of findings that looked at quality of life as well. Then there was Safely You Guardian, which was a continuous video monitoring system that looked at when people fell in their rooms or fell at home, and that could then trigger an alarm. Someone could see what was happening and they could trigger someone to go and help them. And they did find that that significantly reduced the time people spent on the ground, which is important in their recovery from falls. But it reduced the time on the ground and it reduced the time to assistance. So 76% of people were assisted in under 10 minutes in that study. And then finally, there's a feasibility RCT of a standing tall app, which is a home-based fall prevention exercise program delivered on a tablet. And that showed acceptable usability, enjoyment and feasibility with people living with dementia. But it was a very small scale study, and really there's a need for a lot more, a fuller powered RCT looking at that in more depth. Oops. So really just conclusions. We know that digital technologies have the potential to reduce risks for older people living with dementia and help them live in their own homes longer, which is obviously what we've been talking about earlier and is really important. But there's really not enough good quality evidence at the moment to recommend which technologies are best to support people. We know that people with dementia have higher fall risks, but that, as I said earlier, they're often excluded from such studies in testing this technology. And there is some evidence from ABATE that people with dementia find the use of technology systems upsetting and may become distressed. So I think it's even more important to include them to make sure that we're developing technology that they can find usable and make as acceptable to them. But it's a real challenge to get people with cognitive impairments and dementia into those studies. So I think finally, just to say that both the effectiveness and the cost effectiveness of technology for falls prevention for people living with dementia really is yet to be established, and there's a lot more work that we can do in this area. And if you'd like to look at the full report, it's on our OPFPRU website. There's the address. So thank you very much.
So thank you, Charlotte. That's really fascinating. And I'd just like to open up the floor for questions and comments. From anybody. Has anybody got any questions for Charlotte?
I think there was one hand up.
Where is that?
Yading Chen.
Yeah, I think I have a question about the duration of the study. I mean, of the studies used for evaluation. I think, from my understanding, the inside technologies usually involved like collecting the personal data and modeling based set, and it may just take time to do that. And if you are doing some kind of research on it to evaluate its effectiveness, it may take time. And I don't know how you compare different technology given different period of studies.
I agree. And the studies that were included did have a range of different times, but so some of them were 6 months, some of them were a year, so they did vary. But I agree with you that you obviously need time for technology to embed in and get used to. But I think there's such a paucity of information there that really, you know, until we get more studies, you haven't even got that information there yet, I don't think. So.
Yeah, okay, thank you.
Thank you. Jason, you'd like to ask a question?
Yeah, an interesting area, isn't it? And so so full of advertising promises and so devoid of evidence. I think it's really tricky because we actually need new study designs to help us evaluate these things better, I think, because particularly for me, you know, evaluating an app is really difficult because it's not a static intervention. An app changes over its lifetime and hopefully improves, but you know, it doesn't. It's not a one-off intervention. So just doing an RCT of one versus another is not really realistic, and probably is very different from the way we should be evaluating things. And so it's quite difficult to commission research in this area for me, and frustratingly so, because I think we really do need some better answers, but we want to be able to believe the results we get as well. And you know, the example I use to people is, if you imagine something like Google Maps now, and Google Maps as it was first conceived in 2005 or 6 or something like that, when it first came to a telephone. It's changed immeasurably and does loads more things and has loads more functionality, and is sort of more ubiquitous in our lives as a result of that. So it's quite difficult to think how we could study these better, and it'd be interesting to know if, you know, any of your work had come across really innovative, clever study designs that we should be using, or has everyone just gone for an RCT because that's what we're telling them they should be doing?
Well, in this study, we were only looking at reviews of reviews. So we were looking for, you know, that kind of gold standard of research. But at the same time, I agree with you that we may have to look at other ways, because once an RCT is conducted, this is so fast moving as well that we've moved on to the next iteration. And I think it's probably about trying to get people involved at an earlier stage. So before it goes out to RCTs, to get co-creation at the beginning with people with dementia, if it's going to be targeted at that. So yeah, I think it's almost bringing them back in a lot earlier in the process. But then again, sometimes you don't know what you don't know, do you? So yeah, I think.
And it's also fascinating to sort of contrast with the world of dumb tech, you know, the things that we do to stop people falling that doesn't have a microchip in it. You know, because I found when working to sort of commission in this area, those sorts of interventions were often hopelessly undersold compared to all of the new promising wonderful digitally based things. And so, you know, the importance of putting rails up and, you know, making sure that the trip hazards are removed and doing all the sort of common sense basics were often being overlooked sometimes at the expense of all of the new shiny stuff.
Well, yeah, that's good. I think that's sometimes the problem. We have the shiny stuff and we want to put it out there, but I think we need the evidence base to know sort of more what shiny stuff we should be putting out there. So yeah.
Indeed, yeah, fascinating. Thank you.
Thank you.
Thank you so much, Jason. Geraldine's got a question for you, Charlotte.
It's thank you for your presentation. It's less of a question, well, it's partly question, partly observation, really. I think although these digital technologies sound as if they're things that you can just parachute into people's lives, but I think your review and the discussion makes it very clear that it's actually quite a complex intervention. And I think rather than going straight to should it be an RCT or should it not be an RCT, which I think we do a bit too quickly in our field, I think there's a case for treating it like a complex intervention and doing more of the upstream work that's needed around theory of change, issues around implementation, so that we end up designing and co-designing with service users and carers and professionals an RCT that makes sense.
No, I completely agree with you. But I think it's about, as I say, knowing that the evidence isn't there and knowing that we need to gather that, because the next stage of this is probably going to be looking at what evidence we need to gather and how we need to, as you say, move upstream to get that information from people before an RCT.
Yeah, if I could also just add one other thing, is that we often talk about the problems with RCTs, when in fact, nothing I've heard said about this topic wouldn't apply to observational studies as well.
Okay, thank you, Geraldine. Martin.
Very briefly, because I never disagreed with Geraldine. I'm not going to disagree now. I think Geraldine captured it really well. But I think the challenge we've got in this area is that the interventions are likely to have consequences over quite a long time and might be slow. And that was the first point. On the other hand, we've got technology that's changing very quickly and contexts that might be changing quickly. So we actually want fast interventions. And this is where I think researchers really do need to think about how they can adapt their design. And what people often point to is in the medical devices area where technology is moving very fast. I think evaluation has, I don't know what's done there, but we need to find a way of evaluating things where the technology is changing rapidly or the care context is changing quickly, but the consequences are going to be slow to reveal. And that's quite a challenge methodologically. Sorry, so that's just repeating other people's comments.
Thank you, Martin.
Did you want to say anything more about that, Charlotte? Because we've got time.
Well, no, I think I've just said it, that I agree that we do need to find novel ways of looking at it, but I think we needed this evidence to know that we don't know what's happening really. So I think, and obviously there's technology that's developed for older people, and it's almost like putting another layer on looking at older people with dementia. So we're not that great at testing technology for older people yet, let alone older people who have cognitive impairment. So yeah, and how we involve them in the studies as well is really important.
No, I thought that was a really important point about trying to get the technology right in the first place. Yao Ding, you wanted to make another point.
Yeah, I mean, I just think about the fact because just mentioned that many people said it's hard to recruit people for such studies, but my perception is that there's many companies that have a huge amount of data in their database about all kinds of like behavioral data of human beings, but they are just not like mined by the people. And maybe we just don't need to like to do all kinds of I don't know whether I'm right or wrong. I mean, there's definitely a lot of information in that kind of database, but I'm not sure whether we still have the access to the data and how this may change the whole evaluation process. And I think it might be helpful for a better evaluation for the future if we can access to the data and combine it with like clinical reports or something like that. It will be quite helpful.
Thank you. I agree that if we could mine that information, it might be useful, but we do have to obviously consider ethics and, you know, whose information it is and how it's being collected. Because if it's a big tech company, then we don't know how they're collecting that information and how biased it is really. But obviously, as a big tech company, they're going to want you to be using their product.
I mean, that's definitely an issue, but they definitely have a lot of data, but they just we don't know how to use it so far.
No,
like for example, Apple Watch is like quite widely used, and it also has some function about fall detection, but we just don't know how useful it is. It might be, and we don't actually have the access to the data, and maybe we can in the future find some way to. And anyway, I don't know what's the best practice here, but maybe there's something there that is for the exploration, and if we can have that kind of cooperation with the corps, and it may make a difference.
No, I agree with you, definitely. Thank you for that point.
That's fantastic. So we've got 1 minute left before the closing comments. Any points, anything else that anybody would like to say? So really, it's just for me to thank all the presenters. I've been to both days and all the presentations were absolutely excellent. I'd also like to thank everybody who was involved in setting everything up, Daniel and Angie. Everything seemed to go very smoothly. And also there were lots of really fascinating comments, and I think it just really showcased social care research absolutely fantastically. So that hasn't taken me 10 minutes. So if everybody's happy, then we can just say goodbye and thank everyone again for such an absolutely excellent event. Thank you, Jose Luis, for organising everything, and look forward to future events in the future. So thanks very much, everybody, and hope everybody has a really good evening. Bye-bye now.